Welcome to Healthcare Upside Down with your host, Dr. Nick Vanterhaden, and brought to you by ECG Management Consultants. You can learn more about the show on the program's page at healthcarenowradio.com or on our blog at ecgmc.com/HUD. The U.S. spends more on healthcare per capita than any other country on the planet. So why don't we have superior outcomes? Why haven't the principles of capitalism prevailed? And why do American consumers have so much trouble accessing and paying for healthcare? Each week, Healthcare Upside Down will dive into these and other issues with ECG principal Dr. Nick and guest panelists as they discuss the upsides and downsides of healthcare in the US and how to make the system work for everyone. And we end with your better pill to swallow, the conclusion to today's episode with insights on challenges and changes that improve healthcare. Now here's your host, Dr. Nick.
Automation is everywhere in our lives. It's built into our own personal activities in basic and complex forms. When I arrive home, I park the car and automatically put my keys in the same place. Why? Because that's what I've trained myself, and to be fair, also trained the rest of the family to do. Some of these actions can be presented with simple logic statements that some might remember from their early learning days. If this happens, then do this, otherwise do that. It forms the basis of some computer programming languages, but even with some clever nesting and sophisticated branching, quickly becomes unwieldy and challenging to create complex task rules. Early computing was based on programming languages that incorporated these statements and then added branching capabilities, but the techniques have moved far beyond that, and we now have high-level tools that can ingest large amounts of content and pull it together into some proxy of knowledge. Do you remember Big Blue beating Garry Kasparov in 1997? That was chess and considered a milestone at the time. But progress continued to be made, better tools and knowledge, and IBM made the news again with Watson, the Jeopardy-winning AI computer that beat former champions Brad Rutter and Ken Jennings in 2011. What followed was another gold rush to the nirvana of AI and machine learning solutions to solve everything, everywhere. The reality was different from the expectations, and while the envelope was pushed, there was much to be disappointed about in the trail of failures left in the wake of that hype. Babylon Health launched in 2013 to much fanfare and interest, and overpromising of capabilities, including the diagnosis of disease, more accurately than doctors. Not so much. The trajectory for chess is informative for where this technology might go with healthcare. At the time of Big Blue, there were many who predicted the demise of chess and chess players, but the game and interest are very much alive, but in a more blended and creative way. There are tournaments with no AI or computer support allowed, but there are many that allow the use and support of computers, and even team-based approaches with computers and humans all contributing as members of the team. It is the combination of both human and computer-based systems that creates the most creative and winning teams. Join me this week on Healthcare Upside Down Show, in our series focused on ChatGPT and how it applies to healthcare, as I talk with Dr. John Lee. He's an emergency room physician, digitician, and former clinical informaticist and chief information officer. Hi, John. Welcome to the show.
Thanks for having me. Glad to be here.
So, as part of our ChatGPT series, we're discussing that and talking about the potentials and also some of the pitfalls. You recently used the tool to essentially create or at least pull together a summarization of academic papers. Is that now a job that's disappearing, and we are going to see automation of academic paper production?
I don't think so, at least not full automation. I think the analogy that I think a lot of lay people may resonate with some lay people, most lay people, is that we just like fully automated automatically driving cars are, I think, pretty far in the future, relatively far in the future. But the technology that's being put into that effort is actually going to make driving safer. Things like adaptive cruise control or lane assist. Those sorts of things are the same sort of technologies that are feeding into fully automatically driven cars. But and you can say the same sort of things about technology like ChatGPT. I don't think we're going to generate full out papers, but for instance, in my case, what I did was I put in a fair amount of work on the front end, assembling and curating and kind of abstracting these papers. And I kind of mashed them together. And then what I did was put that output, my output, into ChatGPT and instructed it to put out a 500 to 1,000 word summary, make it academic language, and then out came, really in about 30 seconds, very usable output, which on the back end, I still had to massage a little bit. So again, not fully automated, but helps a lot and can take a lot of the friction and the work out of the process.
So it sounds like it's not full-on automation, not replacement. I think that's one of the things that we hear repeatedly is, we're going to see replacement of activities and importantly individuals. But this was a substantial amount of work to actually prep for it. So the input, and then there were some key phrases in there that I pick out from you, which was you triggered it to do some specific things in the case of this, and academic language. So for me, this is the Chat GPT whisperer. So you're something of a whisperer for using it in an appropriate way. How much work do you think it took to get to that point, and what did it save you? What was the benefit analysis in your mind?
So I think the pre-work took me maybe about 3 or 4 hours. I would say that the process that ChatGPT helped me with saved me at least 2 hours. So it didn't take the entire load off of me, but it did save a substantial amount. And I think that as the capacity of it increases, as its fidelity and accuracy improves, that will become more and more. So that maybe a year or two from now, I could, instead of doing that curation before I put it in, I could just say, these are the papers, these are the abstracts, summarize it for me along these themes, and give me academic language. So then that prep work that took me 3 or 4 hours could be reduced to maybe an hour and a half. And that's where I think this sort of technology will be going in the future. And that's where I think it's the most appropriate usage of right. This sort of technology.
So let's push the envelope a little bit. We've seen, I think good and bad in terms of use cases and examples. And of course, all sorts of people have really tried to push it as much as possible. But, in your particular instance, one of the hard parts of this, in my mind, is actually finding the papers. Do you think it's plausible that it could find the papers, given, of course, that we've seen some examples where not only does it find incorrect information, but apparently seems to make it up? I found that extraordinary, but is there some potential to go fetch and collect appropriate information with guardrails that say, hey, this is valid science, do you think?
Well, I think what you said is key with guardrails. So, for instance, if you say, go fetch the top emergency medicine artificial intelligence papers over the past year, I think it's certainly capable of doing that. But like you said, you at this point, you probably need to be a human to quality control that, where you can say top 50 papers, and then you look at them, and then as a human, because and as a practicing emergency physician who keeps up on the literature, you could say, oh yeah, I'm familiar with these 25. I'm not sure about these other 25. I'm going to quickly peruse them. oh, look, 3 of them are completely fake. I don't know where the heck they came from. And then another 5 of them were uh, poorly written, and they may have been cited or gotten some sort of notoriety. I don't think that they're good papers, and that's where I think it's the combination of the human and using the machine to offload a lot of that arduous work. It's actually very similar to some of the drug discovery efforts using artificial intelligence, where in the past you'd have humans arduously heuristically coming up with different sorts of molecules and then testing it out, whereas now pharmaceutical companies are using artificial intelligence to come up with proposed molecules that may be active to affect some sort of physiologic process, and then you may present a dozen different molecules to someone who's a research scientist, and he'll say 9 of those are stupid molecules, 3 of them have promise, and 2 of them are going to be very difficult to manufacture. Let's focus on 1. And that whole process previously could have taken years or decades, and now it can be. I don't know how long the process is, but I would suspect that it's somewhere between a few days to a few weeks, or maybe a few months. And now you've cut off years to decades off that development cycle.
Yeah, and you bring up an interesting point, and I think it's important relative to all of this. So it's additive, it's supportive, the human oversight, but both you and also in the case of the farmer, you cite examples that in my mind are critical here, and my question relates to this. And it's the ability to tease out, in the case of the molecules, those molecules make no sense. There's something going on in our brains that allow us to provide that oversight. In your example, it was, there were failures in these papers. You could pick them out. Is that something that can be learnt and actually become part of it in the future? Is the potential to do that? Because that seems a critical element as well, right?
Maybe. TBD, very much TBD. And in my efforts as a digitician, informatician, whatever you want to call it, one of the things that it's starting to coalesce in my head is that in Daniel Kahneman's book, Thinking Fast and Slow, what we're trying to do with all of these sorts of things is take system 2 sorts of processes and turn them into system 1. And then when we can't turn them into system 1, we still have the human system 1 heuristics to back it up, which may or may not be absolutely correct. Certainly there are some fallacies in that. But I think it opens up a whole different set of possibilities. And as the saying goes, I'm not sure who coined this, but I think it's really appropriate. That if you it's not AI versus human, or it's AI plus human. A physician isn't going to be replaced by artificial intelligence, but a physician who really uses artificial intelligence well is going to replace a physician who doesn't use artificial intelligence well or at all.
Right. So let me push back a little bit and say we've seen some instances of this. I mean, certainly some software tools that have emerged as a sort of precursor, preclinical assessment. You're an emergency room physician. I think, one of your superpowers is to gather huge amounts of data, discern that really quickly. And it's a wide variation of data inputs. It's not just, verbal, it's all of those things. And then tease out a direction quickly, particularly in urgent or emergent circumstances. But we've seen already, multiple instances of the population going and saying, well, I can bypass that. Do I really need all of that expertise? Where are we with all of that? I mean, it feels like we're pushing out and, maybe edging out some of those individuals.
Yeah, well, so to maybe go back to the Kahneman book. He cites an example of I think a fire chief or captain or something like that who was in a fire, and he walked in. Things seemed, at least objectively, there was a fire, but it wasn't completely out of control. But he said, "We got to get out of here." Something set off the alarm bells, and he said, "Everybody out." And nobody questioned him. They just got out. A few seconds later, the entire room collapsed. There was something about his experience and being able to see the whole picture that heuristically he was able to identify that. I'm not sure if we're going to be able to capture that sort of thing, or an emergency physician walking into a room and saying, all the vitals look okay, but that person looks like crap. I'm going to stay in the room and make sure that that person's okay. Or all the calculations and all our scoring tools point to something that's relatively benign, but I'm going to do a whole bunch of other tests to make sure. Now, that being said, I know there's a lot of fallacy in that too. I know plenty of circumstances where I've over-tested somebody and chased something down a rabbit hole that I didn't really need to. But again, if you use both the human and the technology and use each one of them to do what each of them is really good at doing, then I think that combination, that synergy is where we need to go.
Right. I think great example. I remember that from the book as well. It was very evident, and I think you see it in other places. And medicine is also a good example of that. I think we probably both have instances of that. So, given all of that, and given that you're a digitician, I like that term. You've been exploring these technologies. My sense of ChatGPT at this point is it's not that new. We've seen lots of this. How do we then incorporate? How is this going to be incorporated and start to deliver value and benefit? Because right now it's sort of exploratory. You use it as a tool, but it sort of saved you time. But that's not sort of cemented into a process for you. How do you see that happening, and where are the opportunities?
So you used the word process there, and what I think a lot of people may not necessarily understand when they see the front end of how healthcare is delivered. There's a lot of crap below the surface, a lot of labor and just really difficult things to do that don't yield anything, or that their yield is relatively minimal. So an example of that is I recently was listening to some information about Ozempic, what is it, the GLT-1 agonist that's being used off-label, although I think it's no longer off-label for weight loss. That's sort of a novel thing. And let's say somebody is actually using that sort of medication in that way, I can guarantee you that there's a high likelihood that some of our canned instructions that we often use in EMRs doesn't exist for that. So the classic way to do it within a healthcare enterprise is, okay, we want to create some discharge instructions for these class of medications, and what are you going to watch out for, and have all sorts of other information. The classic way to do it is say, this is what we want to write, and send it off to the endocrinologist. Then more often than not, they'll write something and then they'll have a whole bunch of references, and it'll be written to be peer facing, and we'll say timeout. No, you got to make this 8th grade language, because that's sort of we want to have it the lowest common denominator for the patients. And then we'll send it back to the endocrinologist, and he'll try to do some sort of massaging of that. It'll still not be right, and it'll go back and forth. And that can take months, sometimes even years to do, because the endocrinologist has a day job. So fast forward to using this technology, ChatGPT formulate discharge instructions in 8th grade language for Ozempic and other similar medications, specifically geared towards weight loss and the and whatever key side effects you want to look for. Limited to 500 words. Again, 8th grade language. Outspit something. I can guarantee you that it will probably be not 100% correct, but then at least you have a canvas and part of a picture painted for that an expert. So then you send it to that expert. They make a few tweaks. Somebody does some final editing, and now you've taken a process that would typically take months and turned it into a few weeks.
Yeah, I think interestingly, I've heard similar examples along the way. The sort of shortcut tool that helps bring things together, or reuse of existing information that we know is accurate.
But the contrast to what I think a lot of people are proposing or people are excited about is that they are thinking that I am a patient or I am a physician about to prescribe one of these medications for weight loss. I'm going to tell the computer to spit out discharge instructions on the fly. I don't think that's smart. And I don't think that the technology is at that point yet.
Right. And in many respects, that's about source information. One of the things that really struck me, and maybe, I'm using the free version. I don't know if you're using the paid version, but the free version feels like it's stuck in time. It feels like it's 10 years old based on a couple of applications that I've tried in terms of pulling information out. And to me, it's very clearly about 10 years old. I have some distinct markers because I looked for some very specific information and it pulled it. And when I went and checked it, it was, that was right, but it was right 10 years ago. So there's some concurrency in all of this that I think is really important. So essentially, let me propose. Are you excited about this? And if so, why, and what are you going to be doing with it in the coming weeks, months, years?
Oh, absolutely. I think I am excited about it, but I think it's mainly going to be, at least in the short to medium term, used to reduce some of the labor of some of these sorts of things that we've talked about. And I also think that it can also help with some, like the EMR configuration can be really, really laborious. And I think just like people have started using it for coding, I think we can start exploring ways to turn around some really, really good EMR content in the same way that I described how I produced that content for that paper.
Right. So all in all, exciting times. I think it's presented for the general population, the healthcare population, all of these groups, a potential opportunity. Right now, it's a generalized tool. I think narrowing it down into each of those segments, programming, that's one of the areas I've explored. My programming chops are, very dated, going back to machine language and, COBOL, which actually it probably is pretty good at COBOL because I think there's some significant data points. But, updating to all of that, good times. But, I'm going to pick on the term that you came up with, which is guardrails. And I think that's the appropriate sort of use case. John, thanks for joining me today.
Thanks for having me. Really enjoyed the conversation.
As is more often the case, we find the truth is so much more complicated and interesting than the fiction and the hype. Even in the use case of academic paper summarization, John found the tool to be useful, but still in need of human oversight. It did reduce the friction and work out of the process, but he did a substantial amount of prep work for it, including curation and abstraction of papers. Your better pill to swallow is to open the door to the use cases and exploration of this technology with guardrails and explore how using AI and human expertise together can improve patient care by removing the huge amounts of friction we find in the workings of our healthcare system. Thanks for joining me, your host, Dr. Nick, on this week's edition of Healthcare upside down. Until next week, keep solving the business of healthcare, as if your life depended on it, as one day soon, it will.
That's all the time we have for today. You can find all of our episodes on your favorite listening platform by searching for Healthcare Now Radio. Also, check out our blog at ecgmc.com/HUD for summaries and commentary from each episode. Follow our show's social hashtag, HCUpsideDown. And join us each week as we work to solve the business of healthcare for everyone.